My name is Ismail Kawaya. I'm a medical doctor, but currently I work as an epidemiologist and a biostatistician at Makerere University. That's at the College of Health Sciences. We have a rapid response service. By rapid response, I mean it's a knowledge translation platform that offers synthesized and summarized evidence to policymakers in urgent needs and when they demand for it, meaning that the policymaker is seeking to answer their policy question within 28 days. So within this case, I'm looking at 3 smaller cases to try and show what we have been doing and how our work has been helpful.
We had a development partner based in Geneva, and they'd been doing some work in Uganda over about 7 years on food fortification. They were working with manufacturers and other people in the food industry, and they would give them the knowledge about food fortification, give them the skills, but in addition, they would really help these people to get the resources to fortify their foods. Time came for the project to end. The country manager at the time was really worried that all the gains and benefits they had made over the 7 years were probably going to be lost. If you look at the manufacturers, they were getting a lot for free. If they were now going to do all of this themselves, buy the fortificants, buy the machinery, they were probably going to have to mark up their price on the shelf. This would make them less competitive than those who are not fortifying their foods. And chances are, on average, people will go for the less costly product, no matter what the health benefits are. They probably won't be thinking that long term. So she came in to see us and explain this situation, and we said, well, let's see what the policy options are that you could think about and what they mean. And then you could take it from there with the ministry and everybody involved, all the stakeholders. And what the team will do after having a very good conversation with the policymaker is that they'll go out, look for the best available evidence. This is in terms of the quantity and the quality. So they don't only analyze and make sure that this paper was done well, they also make sure that they've looked almost everywhere that evidence could, because that one paper that you miss or that one source that you miss could be the one that changes a decision over. So the best available evidence, appraise it, summarize it, because nobody's going to read 52 papers of 100 pages each. Summarize it into, say, 4, 5, 6 pages, give some key messages, and return this to the policymakers so they can have an input into the decision. It was clear that for this to survive, it was going to be mandatory food fortification for every manufacturer. So we presented that to them. They were happy with it. However, they felt if we take this, it will feel like we are imposing it on the ministry or on the government or on the policymakers. How can you actually help us to present these options?
This particular case is unique because we don't normally do dialogues. But in this case, the dialogue was very helpful in bringing the different stakeholders. How we organize this is we go to each of them, the different stakeholders, before we give them the evidence that we have before and get their input. We interview them, then we incorporate their input within what we have, and then we send it back so that we get a buy-in and ensure that they actually attend that dialogue. You have to make them be part of that process, and then at the end give them a report that they would agree to.
And so we went through what I would call a rapid policy formulation and enaction, because we took 7-8 months to get the policy enacted. The other 2 case studies came from a district. So after doing this work at national level for several years, we realized the districts were not as active. So we decided to go in deliberately and work with districts on a structure of a rapid response service that works for them. One district called Mukono had several questions. 2 of these questions are what we have cases on. So one was about TB diagnostics. There had been complaints, I would say, or concerns about the period of time that patients get their results back when they go through the TB test. And so they did come to us asking, what do we do? Are there any options of actions or even policies?
So at times we have issues or challenges which we are faced with at a lower level facilities, which we have tried to address but they aren't working out. Health workers at lower level brings in issues which need to be addressed amicably so that for them to meet what? Their solutions there and then. And I get them together here at the district level. I try to look into them, try to make sense out of them before I send it to either Ismail or at the center where they can give us what? Response there and then.
The lower facilities were getting their results very late. They had to hire motorcycle riders to take these samples to these facilities that have these diagnostic facilities. These results that were supposed to take 1 or 2 days end up coming back within a month. And for TB, that's a very critical issue. If you're trying to diagnose TB and the results are coming back within 1 month, you're going to lose that patient.
They gave us different strategies, but we went for one which was using a computer to disseminate results at different centers. And in that, it reduced the time into which a patient would get the results. We worked with partner to install some of the computers in different facilities to help to improve or optimize quality of care in our facility. And we got it. When the results are done, they're sent directly to the facilities. The facility read the results within 1 week. Patients are going to get the results. And if actually it continues in the next 1 decade, I think our country will be on track.
In this last case, there was an NGO that was introducing a program to distribute misoprostol within the emergency kits of pregnant women. There were a number of studies that had shown that it is helpful in reducing morbidity and mortality in pregnant women related to postpartum hemorrhage. Now, ideally it shouldn't be an issue, but misoprostol is also known as an abortion-inducing drug as one of its main indications. Now, in a country like Uganda that is strongly conservative and held in religious beliefs and cultural beliefs, that is taboo. So there was a lot of resistance, especially with the health workers who were meant to distribute this emergency kit. They were unwilling to do that. So the district leadership called on to us to give them evidence about what exactly misoprostol is about, and if it's able to achieve the effect of what the NGO was trying to do.
Their questions really now, it wasn't about a policy option, but how do we actually implement this? How do we deliver it in the community? And again, the team came up with some options, provided this for them. Before we knew it, again, they were sharing the information with other districts.
The evidence which at times is given to us is not contextualized to our setting. What we need at district level is more of an implementation strategies, right? And when implementing, you need one thing, funding, first of all. Then two, you need human resource. So those structural factors, human resource, funding, resources, and others, which comes into that category, at times hinder rolling out of the evidence into intervention. And that's another thing to make people understand that it's not a must that each evidence out there should work as intended. And actually, even at times, even the strategy which could be employed to use that evidence could be the one which is not making it out. The evidence is there, but what strategies are we going to use to make this evidence work? So evidence has tried to bridge a gap between the research and the practice. Because those two arms are different initially. You do more research there, but you come to our district, then you go away. That translating that research into actual practice. So what I've seen evidence doing actually, that it brings the arm of research together and the arm of policy makers or decision makers together, then they bridge a gap. The lesson learned while using evidence in my country, more so in my district, is you become a team when you're doing this. Now, we had the health workers coming out with their own solutions, but when we brought evidence on board, people come together to argue out. And you can't do anything right now before understanding that will this work out? Where is the evidence? And that's the thing which I've learned, that people are becoming more embedded into using evidence. And when you come together, you can discuss more in depth compared to what they would have discussed. Using evidence has brought us together as a team. Oftentimes, health workers or practitioners don't try to consult books, and in due course, they carry out things which are outdated. But of late, what evidence has helped them actually is that when you bring evidence, all of them must read, and all of them are, before they read, then we meet and discuss. In that concept, most of my health workers are now busy reading. And actually, most of them are going back to school as well to understand key things as well. And to me, that's a positive thing which the project has brought about in our practice as well.
So it turns out that at the national level, it's more about policy, and yet at the district level or regional levels, it's really about the implementation. So they will receive the policy, but how do they actually activate it in their own context? We realized that the way we had made the rapid response service before did not really meet their needs. We were thinking policy, and they're thinking more of action and implementation. And so we moved things around, and were able to really have a successful partnership in trying to find a system for them. So what these reviews really intend to do is to get evidence to be a part of the discourse, to make sure that the debate about decisions or the debate about particular policies is really rooted and informed by what the evidence is. I think the Rapid Response Service has been a really interesting and successful strategy of moving evidence into decision making. It has stood out as a mechanism that will provide, yes, evidence for policy making, but it pays attention to the timeliness and the relevance of this evidence. How do we then bring a balance, between, yes, the academic protocols and how rigorous they need to be, and the realities of decision making? Because without your evidence, they'll still make the decision. It comes down to the fact that policy or policy making is really the distribution of resources, power and resources. You miss the train, the resources went with somebody, power went with somebody. Really, for me, the message is, can we all just change our behavior around evidence? Those who are providing it, those who are generating it, the knowledge brokers, can we do our part and do it well? One of the questions that I frequently answer when we're doing trainings or when we're sensitizing people about this is, what if there is no evidence? What if there is no data? And I haven't come across any particular situation where we have failed to answer because we didn't have data or we didn't have evidence. It might be a matter of context, or if we're looking for evidence of it having been done in Uganda, maybe not. It was done somewhere else, and all we have to do is to contextualize it. And if we paid attention to that evidence, maybe we would have our problems. But now, with one of our new funders, they would like to see us working in other sectors as well, other than health. Through our interactions again and collaborations, now we are being skilled in how to analyze and do all sorts of analytics on big data and data analytics. And so just from selling this strategy, many people are able to realize what else it can do, which we hadn't realized on our own. So there's been a lot of benefits, just even sharing what we have been doing.